Hi everyone, I'm Ping. My study title is OCT and OCTA in optic neuropathies. Optic neuropathy is damage to the optic nerve from any cause, such as ischemia, inflammation, compression, and so on. Damage and death of the nerve cells or neurons leads to visual loss and characteristic visual field loss. Some studies have demonstrated that the visual field loss correlated with retina structure and perfusion defects. So, analyzing retina structure and microcirculation changes may improve our understanding of the optic neuropathic diseases and their clinical management. The purpose of our current study is to assess OCT and OCTA features in optic neuropathic diseases. We enrolled optic neuropathy patients with age-matched healthy controls. We excluded patients with other retinal diseases, such as AMD, DR, or glaucoma. All patients have comprehensive clinical examinations and 24-2 hemisphere visual field test. The OCT and OCTA scans were performed using a spectral domain OCT system with SADA technology. Scan regions were peripapillary 4.5 mm and macular 6 mm squares. The scan signal strength index must be more than 55 and also motion-free. We used the QLab custom software to remove shadow from analysis and compensate the reflectance to adjust the signal strength index influence. The projection result post-scan algorithm was used on the GCLP slide to reduce projection artifact. In this pilot optic neuropathy study, we collected 9 patients, 13 eyes, including 8 NAION, 4 pituitary tumor, 1 PION eyes. 31 age-matched normal eyes were enrolled as control group. These two groups had statistically same age and axal length, but the optic neuropathies had higher IOP, worse visual acuity and visual field mean deviation and pattern standard deviation. For all OCT structural thickness and OCTA perfusion parameters, optic neuropathy group were significantly different with the normal group. The optic neuropathy group had significantly thinner NFL, GCC, and GCIPL thickness, lower NFLP capillary density, and SVC GCLP vessel density. In addition, they had larger low perfusion areas and focal perfusion loss. When differentiating optic neuropathy from control, all parameters had good diagnostic accuracy in terms of AROX and sensitivities. Peripapillary neurofibrillary plexus low perfusion area and focal perfusion loss had better diagnostic accuracy. The AROG is 0.955 and sensitivity was 92.3%. The thickness and vessel density had good correlation with visual field mean deviation and the pattern standard deviation. Among them, the low perfusion area and focal perfusion loss still had better correlation with visual field. If only correlated with central 10 degrees visual field mean deviation, the macular GCLP low perfusion area had the highest Pearson's R value. Now I will show two cases in this study. The first one is a 51-year-old male. He was diagnosed pituitary microadenoma many years ago with bitemporal hemianopia. On this patient's both eyes, the GCLP and NFLP's microcirculation loss on the nasal hemisphere of peripapillary and papillomacular bundles regions. The thickness of GCC and NFL also decreased in corresponding regions. These were corresponding well with visual field loss. The microcirculation reduced area were highlighted on the perfusion maps. The second case is a 52-year-old male. He was diagnosed NAION on right eye about 3 months ago. On structure OCT and OCTA scans, this case showed a horizontal superior hemisphere defects, which were corresponding well with inferior visual field loss. So in this pilot study, OCT and OCTA not only provide quantification of the thickness and perfusion defects, but also provide detailed visualization pattern of loss, which could be useful for the diagnosis and classification of retinal neurodegeneration diseases, just like illustrated on this slide. We can see in NAION, the perfusion loss was horizontal hemisphere, but in pituitary tumor, it demonstrated vertical hemisphere, while in glaucoma, the perfusion loss was accurate. All the perfusion loss were corresponded well with visual field loss. Conclusion: in our study, OCT and OCTA provide detailed visualization of the peripapillary and maculoretinal changes, which correlate well with visual field loss. The patterns of loss could be useful for the diagnosis and classification of optic neuropathies. The quantification of thickness and perfusion parameters could be useful for assessing disease severity and progression. Here, I want to thank for Dr. Huang, Dr. Falado, Dr. Jia, and thanks for Liang and Jie. Thanks for all my CoLab colleagues. Thank you for attention.